And thank you to the IME for their support with this project and other projects like mine. So I'm going to be talking about the use of mixed reality for enhancing neuraxial anesthesia training for our anesthesia residents. I do have a disclosure that just out of an abundance of caution, I will report. I received the Anesthesia Patient Safety Foundation's basically investigator-initiated grant, which they deemed the Medtronic Research Award for a study looking at pulse oximetry. It's unrelated to this. Medtronic didn't give me any money. They gave money to the APSF, but I'm reporting it. Okay, so in terms of what we're going to be talking about today, we'll start with a little bit of background and rationale for this project, as well as a brief overview of the relevant technologies. We'll also talk about the study design, some of the preliminary results we have, and what future directions might we take. So in terms of background and rationale, neuraxial anesthesia can kind of be split into two different categories, both epidural catheter placement and single shot spinal injections. They're very commonly done for a very common anesthesia procedure, either as a primary anesthetic or as a kind of an analgesic adjunct to a general anesthesia. This is one of the procedures that we still do landmark based. So, although you can use ultrasound or fluoroscopy, the standard for this type of procedure on the labor floor or in the operating room is generally going to be landmark based. Because of that, it's a little bit more difficult for our trainees to learn because it's based on a sound understanding of the underlying anatomy, what types of anatomical variations there might be, and it's really based on feel, both feel of moving through different tissue planes and ligaments, but also just kind of getting the patient into the right position and getting an understanding of what you might need to do to troubleshoot that. As you can see here, as you start trying to troubleshoot getting into the right spot or using alternative approaches like a paramedian approach, there's a lot of understanding of the underlying anatomy that needs to happen that initially our trainees may not necessarily have. There's been a lot of different studies looking at the best way to teach neuraxial anesthesia. There's no high quality studies that say one specific way is better than the other, but I think for the most part, people are learning kind of in a see one, do one, teach one type of scheme. So we're trying to think of ways that we might be able to improve upon that. Because I've talked about how important anatomy is for neuraxial anesthesia, I think it's important to talk about kind of what the current state of anatomic education in undergraduate as well as graduate medical education is. Cadaver labs once were kind of the standard for like full body cadaver dissections were the standard for undergraduate medical education for many, many years, but the resources required for cadaver labs are definitely high. They require a significant amount of space, of time, of money, of people. So there's been a trend towards kind of shifting towards either the use of pro sections that don't require full body dissections that can still be used multiple times, as well as the use of hybrid training systems, so digital or virtual systems and things like that. I previously did a study looking at anesthesia specifically, and about one third of residencies within anesthesia and about one third of regional anesthesia fellowships are utilizing cadaver-based education in any form. Now, that might be actual dissection and kind of understanding the underlying anatomy, but it could also just be the use of cadavers for procedural practice, which is another common use case. Um, we've been beneficial enough to be able to run cadaver-based anatomy courses for our residents and our fellows at Mount Sinai, and I don't think that you can really replace the ability to kind of practice on procedures and then dissect out those tissue planes and get a better understanding for the underlying anatomy. But if there's anything we can do to supplement for those programs or those situations where you can't have that full cadaver experience, that is something that we're kind of trying to aim for. One such solution could be the use of mixed reality. This is an example of a mixed reality system that we use. It basically overlies a virtual cadaver, and then you can use a basically a digital pointer to peel away different anatomic structures and essentially virtually dissect the relevant structures. Now, the benefit of this is that it is very portable. It can be used in a simulation lab. It can be used in a conference room. Here in this image, they're actually using it in an anatomy lab as a supplement to cadaver-based education, but really can go anywhere. It also is very repeatable in a way that a cadaver, once it is dissected, is difficult to kind of repeat that process versus a digital system, you can just reboot it. It doesn't have quite the same level of immersion, but it is fairly immersive. And then once you're past the upfront costs of hardware and software, it is fairly relatively cheaper to maintain versus a full-on cadaver course. So just to get a little bit into the different types of technologies so that we're all on the same page, I want to talk about the extended reality spectrum. Really, this is kind of a spectrum from augmented reality all the way to virtual reality. And then mixed reality, which is what we're going to talk about here, is kind of the blending of the best of both of those worlds. So, virtual reality, this is an example of a fully immersive, fully virtual world. This was a study that we did on VR for ACLS management. So, on the left-hand side, you see there's learners that are wearing a head-mounted display. They're able to just sit there, but whenever they look, they see the images on the right. It's a completely virtual procedure room with virtual avatars for nursing and support staff, as well as the virtual patient monitors, and everything is in that virtual world. On the other side of that spectrum is augmented reality, which is more reality than virtual, right? So this is an example of an anesthesiologist who's wearing a head-mounted display, but is still able to see the rest of the world. He has his real world information augmented by a small little icon that shows what the pulse oximeter saturation is. You're not really able to interact with that too much, but it is augmenting that real world experience. Now, mixed reality is kind of a blending of both worlds. So you're able to see your outside surroundings, you're able to interact with your outside surroundings, but you're also able to really immersively interact with virtual components. So in this example, again, is a virtual cadaver. You're able to do things like ventilate a mannequin that has the underlying anatomy visible, and you're able to peel away parts and interact with other learners as well. So, what did we actually do with this study? So we basically used that virtual cadaver software with mixed reality to create a neuraxial training module. So what we did was we basically selected out what components of that virtual cadaver were important to us for neuraxial anesthesia. That would be things like obviously the spine, the pelvis, all the ligaments that are encountered as we traverse into the epidural or intrathecal space, the overlying musculature, vasculature, etc. We also were able to create a slide deck module that has kind of a guided session that allows you to tell the learner to pull out the lumbar vertebrae and examine it and examine it at all angles and kind of walk around it and really understand what that anatomy looks like so that as we're performing a procedure, you're able to understand what bony structure you might be hitting and what you might need to do to adjust your approach so that you're able to get into the right spot. It also kind of went through all the steps necessary for a neuraxial anesthetic in terms of preparation, performing the procedure, and troubleshooting. We did a block randomization for this, having the experimental group utilize the mixed reality system and the control group experienced an educational video that was based on that same slide deck that just had a narrated instructor. We we chose to use PGY2 anesthesia residents in their first clinical year of anesthesia during their OB anesthesia rotation. Now, most of our neuraxial anesthesia training is during this block. Occasionally, a resident may have done a spinal or an epidural in the general OR, but generally, most of this educational experience was during their OB anesthesia rotation. So we wanted to pick this as a time point where we could really um, kind of have them all in one spot to really run this study. So that was done in week one. And then in weeks 3 and 4, where we collected our outcomes. So things like observed spinal anesthesia procedure performance, as well as confidence assessments, knowledge assessments, and subjective feedback. Now, both groups were able to utilize a task trainer during the learning module. So they would interact with the mixed reality or the video system, and then they would be able to practice those steps on the task trainer during that initial session. The benefit of this, particularly for the mixed reality, is because you're able to see the outside world and interact with real world things like a task trainer or neuraxial anesthesia supplies. We're able to kind of practice that procedure while still being able to correspond with the virtual spine and the virtual prosection. So that kind of helps them get a better understanding of where their needle might be and what they needed to do to address that. Now, our primary outcome was a validated metric for observation of spinal anesthesia performance. We picked spinal anesthesia over focusing in on epidural just because it allowed us to pick scheduled C-sections, which were controlled environments, and we weren't withholding any amount of analgesia during labor or anything like that. But it also because there was a very nice validated metric for us to actually assess their clinical performance. And this metric basically looked at two different time intervals, a global rating scale score that looked at 6 different domains, and a checklist of 11 common errors during spinal anesthesia. Other data for our secondary outcomes looked at the data from observations. So, was verbal assistance from the supervisor required? Was physical assistance required? And was the procedure taken over by the supervisor completely? Other post-rotation data, we looked for a change in their spinal anesthesia confidence, which was a validated metric for confidence in their ability to perform spinal anesthesia. A change in their spinal anesthesia anatomy score, which was a self-created, basically labeling of all the relevant ligaments, muscles, bones, structures, etc. And then finally, a perceived benefit to the training mortality. All right, so next we're going to get into our preliminary results. We had a little bit of a delay with some of the IRBs, so we were a little bit delayed starting. We have 27 subjects thus far, but if I think we're kind of planning on just extending it through the end of this academic year, so we're going to end up with a fairly good sample size for this study. So what we have so far, we've had 14 in the control video group and 13 in the mixed reality group. As I said, we're only using PGY2s, so our PGY2 is 100% in both groups. We have similar baseline spinal anesthesia confidence, 25 versus 24. Slightly improved not baseline knowledge score of 87 for the educational group, but very similar in terms of baseline number of spinals prior to the rotation and the exact same number of spinals performed during the procedure. So, or during the rotation. So, somewhat similar baseline demographics. Now, unfortunately, our observed clinical outcome of improved performance of spinal anesthesia didn't necessarily show anything in terms of time points, error counts, or anything like that. We did have global rating scale scores increased in the mixed reality group. And I think with our current sample size, we just didn't quite make it to that zero point zero 0.05 threshold with a p-value of 0.06. I'm hoping that as we continue to finish enrollment, that number is gonna make statistically significant findings. But overall, you can see that both groups tended to do fairly well. And when you compare these scores with the previous validation study of this metric, most of these scores align with kind of the intermediate learner, not quite novice and not expert. So I think that makes a lot of sense. In terms of the other secondary outcomes, there was no statistically significant difference between verbal assistance or physical assistance required, as well as the rates of supervisors having to take over the procedure. There was a statistically significant difference in change in spinal anesthesia confidence. So the mixed reality group had about an 18-point increase versus the video group had a 10-point increase. Uh, but no change in spinal anesthesia anatomy knowledge in terms of statistical significance, and no difference in perceived education benefit, though both did tend to score um, high, fairly high. So in terms of future directions, obviously we're going to complete data collection over the next several months. Hopefully we will see that there may some of those things that were borderline may reach statistical significance. But overall, it appears that mixed reality can serve as a potential modality to support anatomic knowledge for anesthesia procedures like spinal or epidural anesthesia. It did increase confidence in spinal anesthesia, which I think is important for our learners, but we didn't quite reach that improved clinical benefit, which is always something that we really want to see in an education study. Um, Overall, both modalities had perceived positive benefits, so I don't think that it's anything that we need to stop doing or anything like that. But hopefully, we can kind of bolster some of that evidence in terms of the benefits for it. Um, and that's what I have for my challenge grant.
And second is that communication makes a big difference for how patients feel about their doctors, which of course we all think is super important. I thought House did a great job of checking for understanding, but next time he's definitely going to work on expressing more empathy for the patient. Many of you that are attending this probably already agree that teaching and learning about communication skills is important, but are worried that it takes time. The internal medicine residency includes 165 residents, meaning that scalability and time efficiency and feasibility was really important for us too. And the approach that I'm going to show you, we scaled to over 50 PGY2 internal medicine categorical and primary care residents, and we implemented this in their required behavioral health rotation. This is the approach, and I call it brief direct observation. There are two parts. The first part is called preparation and happens simultaneously to when a learner presents their patient. And instead of describing this to you, I'm going to play an audio simulation because I feel like audio is much more fun than just listening to me reading off the slide. And um, since this is a communication project, that's what I'm going with. Disclaimer, I didn't invade anyone's privacy and the recording isn't of an actual learner, but it is based on a few real scenarios. So let's listen to what the framing step sounds like.
Thanks for seeing Miss Jones. Our focus today is going to be working on your communication skills. So feel free to give me a briefer presentation than you normally would, around 1 to 3 minutes. And I'll make sure to answer whatever questions you have for me before we see Miss Jones together. But most of the teaching you'll get today will be after I've watched you finish up with Miss Jones.
Most residents will love being asked for a briefer presentation because they're more or less used to having to present longer. Um, and the framing step here is critical because learners in internal medicine, and perhaps your specialty too, if you're in a different one, aren't used to communication being the learning goal. And everyone here that's listening in has probably already presented a ton of cases or listened to a ton of cases. So I'm going to skip the case presentation portion. But I will mention that one big goal of the case presentation step is to ensure your learner feels comfortable talking about what they're going to be talking about with the patient. Because it's very hard to teach communication skills if the learner isn't comfortable with the subject content. Um, so we're going to listen to how to navigate transitioning to the observation and how to set rules for that.
Is there anything else you think Miss Jones will ask you that you want to learn about first?
I think you answered all my questions. Thank you.
Great. For when I observe you with Miss Jones, is there anything you're working on in terms of your communication skills that I should keep in mind?
Not anything in particular, but I'm open to whatever you notice.
I'm going to be a fly on the wall, but if you need me to jump in, ask if I have anything to add, and I'll take that as my cue. If I notice you missed something,
Oh, cut off at the end, but it's important to continue the frame that this will be an opportunity to learn about communication skills and that there will be feedback given. It signals to the learner what's going to happen and makes clear the expectations for the learning transaction. Um, Also very important in the rules is that the faculty establish a possibility that they might leave early. The learners typically don't mind this because it means that their autonomy won't be compromised. And this is great for the faculty because it means you can balance the need of other learners. If you have a ton of other cases to precept, it simply won't be possible to sit in for the entirety of the time that the learner spends with the patient.
critical, I'll briefly interject, but I expect you to pick it up from there. I might leave before you're done, once I've observed enough to give you useful feedback. Can you lead us into the room and introduce me?
The observation can put learners on edge because learners are used to faculty impinging on their autonomy, and this is for good reason. Many of us here won't have trouble remembering a time where we wished our attending let us try or do more in the room with a patient. And in order to preserve that autonomy for the learner, it's critical that the faculty continuously self-monitor and position themselves in the room with intentionality. That can really encourage the patient to continue engaging with the resident or the learner instead of the faculty. Now we move to the final stage of the brief direct observation model, and this is the feedback stage. Let's listen to steps 1 and 2, which are to open with appreciation and to elicit the learner's perspective on how things went.
Thanks for letting me sit in. I know it can feel pretty awkward to have someone watching you.
Actually, it wasn't too bad. I totally forgot you were there for a minute.
How do you think that went?
Good. I built good rapport with her before I presented, and I think that paid off. She's also pretty health literate, and that really helped.
The next step is probably one of the most important, which is teach strengths. This is because most learners overlook the contribution they made themselves towards a positive outcome in favor of external factors. And in fact, in listening to this learner's reaction, you can probably already forecast that the learner is going to be thinking about the patient's so-called health literacy and the rapport that they've built as factors that might have contributed to the positive outcome. And the learner may overlook some of the things that they did to make sure that this went well.
What'd you do in the wrap-up that was helpful?
Pretty much just that. Continued on the rapport.
I completely agree. You had great rapport with her. And I also noticed something else you did. You very soon into the wrap-up asked her, what questions or concerns do you have about that medication? She then only had one concern for you, which was about SSRI-related worsening suicidality. It was great that you invited her to share her concerns because otherwise we might never have addressed that. It also made the wrap-up patient-centered in that it focused on what Ms. Jones thought was important. I noticed it made Ms. Jones eager to ask you questions and engage with you, and I imagine she felt appreciative. You should continue to do that.
Like this one.
Oh, well, thank you. I guess I just assumed she would have questions since she's so health literate, but I should probably be asking all my patients that.
Totally agree.
I totally forgot to listen for this learner's reaction to what I said, which is very important when you're doing this. Like this one, many learners will see their rapport building as their most useful contribution, and they won't be able to recall specifics beyond that, meaning specifically what they said or did that worked well. And it's important for your learner that you do get into those specifics because learning about what they did well is very useful for your learner. It encourages and reinforces positive growth. Now let's listen to the next step, which focuses on an area for improvement.
What about the wrap up felt hard?
Nothing really. Do you have any feedback for me there?
Yes, I only have one piece of feedback. For me, it felt hard to know whether or not Miss Jones knew to take the medication daily. How have you been taught to check for understanding?
There's the teach back, but it's always felt patronizing to me to quiz the patient. Instead, I try to sense their body language.
I totally agree. Body language can be supportive and suggestive for alignment. And if you're open to it, I have 2 tips on checking for understanding in a more patient-centered way.
Sure.
Tip number 1, chunk and check. This is where you give smaller pieces of information and pause frequently to allow the patient to clarify or voice their understanding.
Oh, gotcha. Yeah, I think I've heard that one. I'd have to talk less. What's the second tip?
Teach back, but ask it more specifically, like, how are you going to take this medication?
Oh, I see. So it's not exactly like infant medication.
And finally, just like with our patients, the last step is crucial, checking for understanding. So let's listen to that one.
You did a great job today. I'm just curious to hear, what about our conversation are you planning on bringing to your next patient?
I'm going to start by listening to questions first because I liked that it saved me time and made the patient feel good. And I think I'll try the chunk and check. That feels like it fits with my style better than the teach back.
And that's it. That's the end of the brief direct observation model. In total, the feedback portion might take you between 3 and 5 minutes, and you can titrate to your schedule on who's waiting for you. So now we're going to talk about implementation and what that was like for us. The biggest challenge to teaching communication skills is definitely the time that it takes to do that. But if you already think it's important enough to teach it, there are ways that you can make it work. With a few scheduling tweaks, like for example, appointment stacking and alternating appointment slots, we scaled our observations from about 0 to 1 per observation or per resident per 6 months, all the way up to 1 to 3 observations per residents per 6 months. In other words, we more than doubled the observations that we were able to do, and we aren't seeing any fewer patients than we were before. And for those of you that are keeping track of your RVUs, which is probably a lot of you, you know that only good things happen when you see the patient. Lesson number 2. Teaching communication skills is hard, and your faculty probably never got taught this when they were in residency. And your faculty probably never got trained on how to teach it to their learners. So they're going to need quite a bit of support to feel comfortable and effective in doing this. Here are some of the things that we did. Your local resources may vary, but some examples could include skills checklists, rater training, gathering feedback from learners, and direct observation and feedback as it takes. It's a very meta process. Lesson number 3. Most residency programs, with the exception of maybe family medicine and psychiatry, haven't historically emphasized communication skills the same way that other skills like medical knowledge or clinical reasoning or procedural skills are emphasized. And so therefore, it can feel pretty strange for some learners to engage with this. Some will feel excited and some will feel guarded. But what we've learned is regardless of how they feel about it, all of them actually do engage with this teaching strategy. We gathered multi-source feedback, including survey data from the residents, And almost unanimously, they felt like the quality of feedback they received to be at least very good. And the final lesson, and this is why this matters. Authentic patient interactions make the teaching and the feedback very sticky. I frequently have learners remind me what they've learned the last time they were observed, and I don't even have to ask them to tell me. Establishing a clear frame makes it clear that this is what we're talking about, and it reminds the learner of what they talked about last time. For example, one learner told me, last time you gave me feedback on, and I've been working on, and this was all self-prompted. So to summarize, these are the 4 lessons that we learned implementing. I want to thank the IME for their generous support and also a ton of other folks who hopefully some of them are attending today, but I couldn't have done it without all of these folks and probably more. Thanks so much for attending. I hope I've convinced at least one of you out there to try teaching communication skills to your learners or think about ways that you might implement or highlight this category of medicine into your teaching.